Hello, Emilio.
Hello, Jeppy.
Welcome to the Dermoscopy Excellence
Digital training.
Let's start from the clinical.
Are you ready for the scalp? Some data highlighting a significantly worse survival for acral melanoma.
Here, again, you make the diagnosis because of the arborizing vessels, sharply in focus. So, this is our destiny, my friends. If someone is connecting right now,
Yes.
then they are saying, okay, let's stop seeing this stupid course.
But then, if you look at the tables and you see the reason why.
Melanoma on the face is a lazy guy.
Morphologically, dermatoscopically.
Bravo, my president. Eh? Ragazzi.
Hello.
Hello, buongiorno, buongiorno, buongiorno.
Buonasera.
Buonasera, buonasera, buonasera. Welcome to the happy hour.
Hi guys. You know that today is a very strange day because in Greece we have elections. And and now is the time for the result announcement and so on and so on and so on.
Okay.
And also there is the final of the basketball EuroLeague in which a Greek team participates in the final. So it's
I see.
quite a day.
So we'll have 3 tabs: Dermoscopy Happy Hour, Twitter for results, and then the match.
But where is Nisa?
Nisa, unfortunately, is traveling also today. She will be with us for with a recorded video during the episode.
Okay.
But she promised, and we all promised, that for the last 2 episodes, which will be fun, well, not that the others are not, but
Today will be said. Today will be said. Yeah.
But the last 2 episodes will be hopefully particularly fun. We will be all here all together. Hello, planet Earth. Hi, everybody from Armenia, Uzbekistan, Romania, London, Caserta, Austria, UK, Romania. I guess that today we will not have many people from Greece for the reason.
Actually, someone, Laura Radu, is wishing me happy name day, which is amazing. How do you know, Laura?
That's also true. Today is the name day of Constantinos, you know.
Ah, bravo, Costantino.
Thank you.
Bravo.
Thank you, my
It's
friend.
funny because today is San Vittorio instead in Italy.
Yes, in the Eastern Church is Constantine and Helen.
I see.
So it's like in Greece, like half of the population celebrates.
Vieni qua, vieni. Aspetta che I have to introduce you again, my friend.
How is he?
He became my best friend, let me tell you.
Really?
He's always with me, always with me. Where I go, he comes, you know?
And he's so quiet.
It's quiet because
Because he knows that it's the happy hour now.
Yeah, exactly.
Bene, allora, Sebbi, what is the question of the week? Oh, this is a very general question. How much of your professional time do you dedicate to skin tumors? Let's see. I see that 25 to 50% is fighting against more than 50%. Oh, but this is very, very close, right?
That's so close. And it's very interesting.
Yes. So really, we dedicate a lot to skin tumors of our professional life. So you know that in Italy, in the last week, the dentists were acquiring the possibility to do cosmetic procedures on the face.
Officially, you mean?
Officially, exactly. So, of course, the dermatologists were not very happy. But, you know, yeah, why not? You know, since there's so much people asking for these things. So there's plenty of room for space.
Yeah, but
Bene,
tell me the truth. You don't care at all about this in reality.
You couldn't care less.
There are
well,
many colleagues
actually,
that care. Come on.
Well, no. Well, actually, since I'm the president of the Italian Society of Dermatology, I had to care of it, you know.
Yes.
So, of course, we did a few complaints. Well, especially because, I mean, the problem is that this is the first time that a non-physician is officially allowed to do invasive procedures, which is, you know, something.
Because if we discuss what happens unofficially, then it's
Beauty salons,
Everything.
cosmeticians, estheticians, everyone.
Yeah.
I know a gastroenterologist who specializes in fillers.
Yeah, okay.
But
The
Sebi wants to share something. What you do?
Yes, Sebi, what you like to share? So today,
So he's trying to say, guys, stop this stupid discussion.
Yeah, it's like, stop.
bravo, Sebi. You are a precise director, and I have the feeling that I feel a little bit lazy today. Yeah, so that's why we discuss.
We started chit-chatting. But
That's why
Sebi, exactly at 8:05, he's like, okay, I give you 5 minutes. That's enough.
Enough.
Yeah.
Yeah. But before this, I have to say, because I like it so much, I have to mention Israel, Poland, Slovakia, South Africa, Ukraine, Guatemala, Oman. Come on, I love it.
Beautiful,
I love it.
Beautiful.
All the world.
It is unique.
Canada, Egypt, Nigeria. Yeah, fantastic.
Sweden.
Beautiful. So what is the theme of the episode?
The theme of the episode is practically, the idea continues the theme of the previous episode that we spoke about the face, but we had no time to speak about everything. So we focused on pigmented lesions last week. So this week, we will speak again about the face, but this time about non-pigmented lesions that includes, of course, tumors and non-tumors, which are obviously much more frequent than tumors.
Yeah.
Agreed? Non-tumors are much more frequent than tumors. This is something which sounds very simplistic, but it's true, and it has a significant impact in our daily practice. So the pre-test probability for anything is to be inflammatory. That's the highest probability in terms of incidence. Fantastic. So as soon as Sebi allows me to share my screen, I will. And we will start with the paper, which in fact this time is not one paper, but it's a collection, I would say, of papers. Some of them are not so new. Some of them are brand new. We will go quite quickly, starting from an old paper, which was one of the first trying to investigate what we discussed today. So how do these very common inflammatory disorders on the face look like? Today we know, a few years ago we didn't. So we know practically that I will not go in full detail, but the common entities are typified by specific patterns. So seborrheic dermatitis, dotted vessels and yellow scales, rosacea, polygonal vessels, sarcoidosis, and lupus vulgaris, orange color together with vessels, and lupus follicular plugging at the initial phase. But let's remember this criteria through a series of photographs. Here you see four cases, 4 images with similar eruptions in the malar area, all of them, erythematous and somehow scaly. Clinically, they look quite similar. Well, the upper 2 are more scaly as compared to the lower 2, but anyhow, it's erythema on the malar area. And this is the first pair, left and right, erythematous and scaly. And here we can see dermoscopy. This is just to remind that these 2 very frequent disorders, which are, of course, psoriasis on the left and dermatitis on the right, retain their dermatoscopic patterns irrespectively of the anatomic location. So all psoriatic lesions are typified by dotted vessels, also on the face, and all dermatitis lesions are typified by dotted vessels and yellow crusts, also on the face. So what we expect to see on the trunk, which is dotted vessels in regular distribution in psoriasis on the left, and yellow crusts with very few dotted vessels in dermatitis on the right, that's the same thing also on the face. And this is the first teaching point that I would like to remind. So the pattern of these two disorders remains identical also on the face. This is the point number one. Then it's maybe even more interesting to discuss a little bit about the lower two cases, which are quite similar from a clinical point of view. But here comes dermoscopy to make a difference, because if you compare the two images, I guess that the main difference is that in the image on the left, there is quite a lot of plugging, while in the image on the right, there is no plugging. Other than this, they look quite similar. So they have a few vessels, not so predominant, linear, maybe some kind of erythema in the background, but the one on the left is also predominated by follicular plugging. And this, as suggested by several other papers which were published throughout the previous years, this is the spectrum of lupus erythematosus. So discoid lupus at the early stage is predominated by follicular criteria. That's an exemplar case with many follicular plaques. And of course, we also see additional features, especially as the disease progresses. So when it becomes more at a late stage, we see not only plugging, but also we see white color because of the fibrosis. We see telangiectasia because of the atrophy. So that's more or less how discoid lupus looks like. In contrast, the other two versions of lupus, so subacute and acute, were very recently investigated. And in these ones, unlike discoid lupus, we don't see follicular plugging, at least not intense follicular plugging. In contrast, we see this background erythema and these few linear vessels. So if we go back in the two cases that we saw earlier, the one on the one on the left was a discoid lupus, while the one on the right was a systemic lupus, a chronic acute lupus erythematosus. That's why we didn't see plugging at all. And finally, the last thing, I will skip this one because I would like to show you a few cases of on another very important entity, which is very frequent, which is rosacea. Of course, this is the frequent pattern. We all know it. Erythematotelangiectatic rosacea with polygonal vessels, but also there are additional subtypes of the disease that have their own dermatoscopic features. Papulopustular psoriasis, we see the pustules dermatoscopically. Glandular or phymatous rosacea, sorry, not psoriasis, of course, glandular with enlarged sebaceous glands with these yellow clods predominating, and also granulomatous rosacea with the orange clods that correspond to the granulomas, and finally demodecidosis with these characteristic keratin projections that protrude out of the follicular opening. So this is the spectrum of rosacea from a dermatoscopic point of view. So that was it in terms of theory, so reminding some basic features of some important disorders. And I will finish with concluding the quiz that we stopped last week. We will see three quiz, the one after the other. Let's start with the first one. So that's these are again three clinical photographs. and non-pigmented lesions on the face. And here my question is how many, wait a moment, Sebastiano, we have to see first dermoscopy. Fantastic. So now is the question, how many squamous cell carcinomas do you think that you see in this slide? And the possible answers are, of course, 0, 1, 2, and 3. And let's see which will be the most voted answer. One
about 50%, yeah.
One about 50%. Fantastic. Okay. Let's see. So this is the first one. And of course, this is the prototype of what? Of
Okay.
actinic keratosis with the background erythema, the follicular openings of strawberry pattern. So yes, this was an actinic keratosis. Then the second one, quite interesting. We discussed about this topic in a previous episode. We have once again the background erythema, once again the follicular openings, but quite a lot of hyperkeratosis also on the surface. And in addition to these features, we also see scales, and we also see vessels, and we also see a structureless white color. And these two features, vessels and structureless white color, are suggestive of an invasive tumor, not only superficial, not only intraepidermal actinic keratosis, but invasive squamous cell carcinoma, which was the case, the correct answer in this one. And finally, the last one, quite similar, obviously, from a clinical point of view, but dermatoscopically predominated by what? What would you say that predominates here?
Follicular plaques.
Follicular plugging. Of course, again, there is erythema, again, there are scales, but follicular plaques predominate, and this was a case of discoid lupus. So the audience was correct to vote that one was the squamous cell carcinoma. Quiz number 2 for today, on another very interesting differential diagnosis on the face in non-pigmented lesions. How many basal cell carcinomas do you think that you see here? These are the clinical pictures, and this is dermoscopy. And let's launch the question again, Sebastiano. So how many BCCs do you think that you see here? Obviously, the lesions look quite similar, but there are also some differences that we will highlight in a minute.
Because one of them looks clinically very much like BCC, but dermatoscopically not at all.
Yeah. So again, we have number 1 as the most voted answer, 55%. So first of all, 1 is the correct answer. Now let's answer what are the other 2. What do you think that are the other 2 lesions?
Dermal nevus.
Right? Yeah.
Dermal nevi, exactly. Yeah. And this is a quite interesting point because it's true that sometimes on the face, it's a challenging diagnosis because some nevi, like the ones you see here, have vessels that are a little bit larger, a little bit longer than the usual comma vessels, and sometimes there is a differential diagnostic problem with BCC. But there is also a difference, which is, in my view, highlighted well in this image. In the lesion in the center, the vessels are much more bright red. So what we used to say in focus.
Exactly.
They are not. Say
that this is a very good example to clarify, because often this sharply in focus that we say is not very well understood. This is like the perfect example. Look at the image in the middle where Emilios is showing, and look at the images on the left and right.
Yeah.
Like, these are the vessels are predominating the images here.
And also, if you compare the vessels that I show here with the vessels in the surrounding skin, again, you understand the difference, blurred versus in focus. And also, if you compare them with the vessels in the 2 nevi, which are on the left and on the right. So the first one was a dermal nevus, the second one was a basal cell carcinoma, and the third one was a dermal nevus. Again, by the way, that's a nice study that showed that, as I said earlier, sometimes in our routine life, it happens to excise a lesion because you think it's a BCC, and it comes back, the pathology report, as a dermal nevus. It's not the end of the world. It happens sometimes, but if we know the clues, it will happen less frequently. And finally, my last quiz. Three images again. How many benign? This is the question. Where is the third image? Ah, here it is. Okay. So how many benign? 0, 1, 2, or 3? And here I would like to have a very, very large majority.
I think more than 70. More than 70, yes.
Yes, yes, yes. Let's see. Let's see. Hopefully, yes. Oh, no, more than 70. No, more than 70.
Close.
We had 65, which is a good majority. Of course, the correct answer here is 0. Now, if it comes to the specific diagnosis, it would be really challenging. Why? Because they are all identical one to the other, more or less. The first one predominated by red color, ulceration, hemorrhages, and many but small vessels. Look at the vessels. They are nothing. They have nothing similar to the vessels of BCC. They are small and many. In this case, this was a poorly differentiated squamous cell carcinoma. The next one, more or less the same story. Again, red color, hemorrhage, ulceration, many vessels, not large, but many. So very similar to the previous one. But in this case, the diagnosis was atypical fibroxanthoma. The last one, again, same story, red color predominating, ulceration, hemorrhages, vessels. The diagnosis was Merkel cell carcinoma. So we know pretty well that all these tumors that very frequently develop on the face or the scalp are similar among them, but this pattern is highly suggestive of a malignant tumor because no benign tumor can look like this. I don't know if you can think of any exception, but I think that no benign, maybe pyogenic granuloma sometimes might be a little bit.
Or heavily traumatized seborrheic keratosis, but not that ugly.
Yeah, yeah. Fantastic. So that was
wonderful, wonderful, wonderful. Very, very good overview. A lot of things, by the way. Many different entities coming on the face. I mean, head and neck is the most fascinating area of our professional life. Don't you think so?
Yeah, absolutely. Absolutely.
Very nice.
With a broad differential diagnosis, as we saw in the case, very broad differential diagnosis.
There is a question from Carlos. How do you feel evaluating vessels in ulceration areas? I feel they are much more not reliable.
Absolutely correct.
Yeah.
Of course, when there is a extensive ulceration, then it's difficult to assess anything else. But the ulceration itself is informative because, I mean, there has to be some explanation for the ulceration. Of course, there are some inflammatory disorders that ulcerate, like the beloved erosive pustular dermatosis of the scalp. But in general, it's a suspicious clue. Any clue for the diagnosis of granuloma faciale? I didn't comment. There was the granuloma faciale in the table. It looks, although granuloma faciale is a vasculitis pathogenetically, morphologically, it's quite overlapping with discoid lupus. It's not a granuloma, so we don't see orange color also dermatoscopically. It's quite overlapping with discoid lupus. I don't have any very good clue to tell them apart, except of the fact that in discoid lupus, usually the follicular plugging is really much more predominant.
So just maybe we can add some cases to your to the discussion.
Of course.
So the first case is coming as this lesion here on the anterior part of the ear, and this is what you can see dermoscopically. And now, Sebi, can you give the question? It's very simple. The question is, do you feel that this is belonging to one of the three musketeers? What are the three musketeers? BCC, SCC, and melanoma. Okay? And of course, something else is all the rest. Okay, let's see. Well, yeah. So the winner is one of the three musketeers, and probably most of you voted for squamous cell carcinoma.
Yeah.
Yeah. Why squamous cell carcinoma? First of all, because we don't see the clear-cut arborizing vessels and sharply focused vessels of BCC, and we see a predominantly ulcerated nodule with just a few white circles at the periphery, very few. So most probably this is a poorly differentiated squamous cell carcinoma, which is, by the way, not very easy to identify, and especially not very easy to differentiate from other malignancies of the head and neck. And the reason why I want to show you this collection is because we have a lot of let's say pitfalls, because usually the Three Musketeers are very easy to identify. Sometimes they are not, but the world of the other benign and malignant tumors that can involve the head and neck is so huge that it's not so easy to identify them. So this is the second case. It's a small papule on the lip, and this is what you can see dermoscopically. So one of the Three Musketeers or something else.
Interesting.
Interesting,
nice lesion,
right?
nice lesion.
So I was, I was fighting with this lady for, 20 minutes, to convince her to excise this lesion. Because I said, this is a basal cell carcinoma. We have to do it. Come on. We have to do it, because otherwise it will grow and grow, and then it will be more and more difficult.
Yeah.
But then you know what it was?
50-50, by the way.
Yes, 50-50. Trichoepithelioma.
Trichoepithelioma, yeah.
So then she was shouting at you, saying that I was telling you that
Yes.
you have to excise it.
So a trichoepithelioma is a lesion mimicking exactly the same as BCC basal cell carcinoma, but it's benign. So if you don't excise it, it will not grow. So she was right, to resist.
Well, it will grow, but it will not destroy, the tissue and so on and so on.
Exactly.
It's so interesting that it even has in-focus dots. It's like, this is a BCC, come on.
This is a BCC, it's incredible. Now, let me give you another example. This is, as you can see, not anymore a young lady with a very scaly lesion on the cheek. This is what you can see dermoscopically. And again, the question, one of the Three Musketeers or something else? So, of course, I see that most are voting for one of the Three Musketeers, thinking about what?
I guess squamous cell.
This
was, of course, our diagnosis. But in this particular case, can you imagine this was an association between an actinic keratosis and an initial Merkel cell carcinoma? Can you imagine?
Really?
Really. So the actinic keratosis is just on the left side mainly, and the Merkel cell started on the right side. As you know very well, Merkel cell carcinoma is, when located on the face, is mainly due to the sun, to sun damage, to the same risk factors of squamous cell carcinoma. That's why sometimes they can also eventually be seen together.
What's strange and unusual in this case, and this is explained by the collision with AK probably, is the hyperkeratosis, which is quite a lot.
Exactly.
For the Merkel, usually in Merkel.
Yes, exactly. So again, a very unusual case, a pitfall. Also teaching us that whenever we suspect one of the Three Musketeers, first of all, we need to make a biopsy. First of all, we need to confirm that the lesion is eventually what we thought, and then we proceed with the treatment. With the management. We show many times this case, but we show it once again. This is a very sun-damaged scalp.
But you have to say what this is.
Okay.
This is the projection. No, this is my projection in the future.
Yes, your destiny, my friend.
No, Emilio, you wear sunscreen.
No, probably it's not the same because this guy is lighter than you. His skin is lighter than yours.
Yes, correct.
So probably it's not. So anyway, this is what we can see dermoscopically, mainly ulcerated lesion with a few vessels. So again, the question is, Seppi, one of the three musketeers against something else.
Desmoplastic melanoma.
Okay, so of course our thoughts went to squamous cell carcinoma. 51% voted for squamous cell carcinoma, but then it was eventually turning out that this is a typical fibroxanthoma. Sorry, a typical fibroxanthoma. What is a typical fibroxanthoma? It's just a lesion, let's say, with the same biology as basal cell carcinoma, so only locally malignant. So we have to treat it because otherwise it will grow. It will never stop growing. But it's not giving usually metastasis, distant metastasis. So again, this is one of these cases in which we first have to make a diagnosis, and then, of course, we have to do a treatment, which is a complete excision of the lesion.
Mm-hmm.
So as you can see, these are lesions for which it's almost impossible to make a specific diagnosis. Here we have the semi-final case. This is a very large ulcerated nodule on the scalp of this gentleman. And this is what you can see dermoscopically. Again, same story. One of the three musketeers versus something else. I see that many are voting for probably squamous cell. Don't you think so? BCC is... well, I would not think too much about, well, okay, there are some arborizing vessels on top, but the lesion is very large, really, it's impressive. Anyway, a lesion that we have to make a biopsy. So we did a biopsy, and the diagnosis finally was pleomorphic dermal sarcoma. What is a pleomorphic dermal sarcoma? It's a very rare malignant tumor, which is very similar in the same family of atypical fibroxanthoma, same family, but giving mets. So atypical fibroxanthoma is not giving metastasis. Dermal sarcoma is eventually able to give metastasis. So they are very similar from an histopathology.
Same family, but very different behavior. So the good boy and the very bad boy.
Yes, good boy and bad boy. Exactly.
Exactly.
So very rare entity, very often located on the head neck region, as is the case of atypical fibroxanthoma. So my suggestion is when you get a report, an histopathologic report of atypical fibroxanthoma, please ask the pathologist that he excluded the possibility of a dermal sarcoma, because they are very similar from an histopathologic point of view.
And by the way, because we had a case very recently, and we're discussing it in our oncology council, there are no clear guidelines on how to manage CAPS, cutaneous undifferentiated pleomorphic sarcoma. No guidelines whatsoever. All the guidelines that we have are from soft tissue sarcomas.
Okay.
And we have no idea what excision margins we need. We suppose that the larger the better, but we have no idea.
Okay.
Yeah, but it's reasonable that for rare tumors, it's difficult to have guidelines, to have evidence-based guidelines. You can only have expert opinions. Of course, the decision to excise is given, and the wider the better. But then, concerning all the other procedures, it's not clear.
Yeah.
What has to be done.
No. Last case. Let me give you last case.
That must be mine.
It's Emilio's.
No, my favorite entity.
Yeah. No, that's what I'm saying.
As you can see here, there is another gentleman who had androgenic alopecia when he was 20, probably, and he developed a lot of sun-damaged skin. And here there are many lesions, many ulcerated lesions. I give you one sample, one dermoscopy picture. And now again, same question, one of the three musketeers versus something else. Wow, something else is the clear-cut winner.
Yes.
Wonderful, wonderful, wonderful. Yes. Okay. So Emilio, this is your best, let's say,
My last, let's say, my last passion, my last.
your last fiancé, your last fiancé.
Debbie, don't say that.
Not
So,
my last, my most recent.
Yeah, your most recent. Yeah. So this is, you know, you can see this beautiful orange color. This is really jumping into our eye. And this is an entity which is, in terms of frequency, growing and growing in the last few years. And this is pustular erosive dermatosis of the scalp.
Well, do you think that it becomes for some reason more frequent as compared to what it was, or simply that we became slowly with time able to recognize it better?
Of course, it can be due to both, but mainly, my view, it's a real increase of incidence, probably related to the increasing use of treatments for actinic keratosis. Yeah. I don't know if this is also your.
Yeah, sure. Because the truth is that in almost all the patients that we see this entity, there is history of field cancerization, actinic keratosis, and so on. In many of them, also squamous cell carcinomas operated surgically. But there must be some connection either to the field cancerization or to the treatments that we apply for the field cancerization. Reasonably, there must be some connection. There are some questions that the easiest to answer is the second. Do we expect to see vessels in erosive pustular dermatosis of the scalp? Yes, it might be. You might see, and sometimes quite a lot of vessels. Yeah. The second, which is difficult to answer, is that what Konstantinos mentioned is surgery enough for the treatment of dermal sarcoma? I don't know if you would like to add something.
By all means. So reviewing the literature, there are some Chinese guidelines that also suggest adjuvant radiotherapy on the scalp or where it's located. However, all of this is expert opinions, and there is no evidence based. This could be a good study for the IDS to do. Gather all our cases and who relapsed, who metastasized. But honestly, our evidence is so scarce that we have no idea. We move based on experience.
Yeah.
But let's say that there is no definite indication for any additional treatment other than surgery, for example, radiotherapy or something like this. So surgery, and then of course imaging with magnetic resonance and so on to understand if it invades neighboring tissues, and also if there are mets, because this is a tumor with metastatic potential, not only local.
It needs staging as like any other invasive tumor. Treat it like a poorly differentiated SC to begin with.
What is the best treatment for erosive pustular dermatosis of the scalp? Here we can say something.
Yes, clobetasol.
It's very responsive, at least at the initial phase. It's very responsive to local steroids, ideally under occlusion, or if you have available in the market these plasters with steroids that remain on the skin for many, many hours, and they slowly, gradually release the drug. It's even better. But in any case, steroids, clobetasol, preferably under occlusion, and 99% it will respond. The problem is that in some of these patients, when you are trying to remove steroids, to stop steroids, in some of these patients, not in all, there are recurrences. And then you have to use again steroids, and this is a vicious cycle sometimes, because with steroids, after a certain point, you induce atrophy. The disease itself is erosive, so it destroys, it consumes the epidermis because of the erosion. So at some point, it might be that you will have extreme atrophy of the epidermis, and sometimes you have complete loss of the skin because of these multiple recurrences. For this reason, in these recurrent cases, maybe according to the scarce literature, systemic retinoids, acitresin, might be a good way to keep the disease under control for these patients that recur a lot.
Do you have any patients like this? What do you use acitretin?
No, many. We do it regularly for those that recur, and
how do they go?
Yeah, we published it also. It's as compared to other efforts to maintain the result, which could be calcineurin inhibitors. That's a reasonable thought that anybody would have. But unfortunately, for this disease, according to our experience at least, they appear not to control sufficiently the recurrences. Or as compared to dapsone, that has been also used in some case series, because this disease is neutrophilic. There is a neutrophilic infiltration, so reasonably dapsone could work since it's neutrophilic, but the results are not so good. So,
of course, the problem is not to put in the patient at risk to develop steroid-induced atrophy. What about acitresin, by the way? Could be in some way an option of the...
That's what I said, acitresin.
Sorry. Yeah.
Acitresin, yeah. It's the best option because, first, because it appears to control better than anything else. And second, because anyhow, if you think that usually we deal with patients with normal melanoma skin cancer and field cancerization and so on, so that's an additional motivation to use acitresin without, There is another question that is challenging a little bit to answer. Of course, it's very specific thing. What about Bapoma? And I was trying to just to find the paper because there is just one, and I found it, so I can share it with you for a second, just to show you. So this is a study by the IDS, a collection of Bapomas. First of all, we have to say that Bapomas are melanocytic tumors with a specific genetic mutation, which is the loss in BAP1 expression. These are considered to belong in the realm of benign lesions in terms of prognosis, but they are quite peculiar morphologically and also in the way that they grow. So according to this study, these are the 6 patterns that have been identified for Bapomas. You can see. Sorry?
Zoom in a little bit so that people can see a little bit better.
Yes, but I think I cannot for some reason.
Okay, let's see.
Anyhow, now that's something very specific. There is, though, a paper. You can go to the paper and read all the available information that we have for Bapomas. By the way, it's a rare entity.
Wonderful.
For the last patient with lesion of scalp, we love to add porphyria cutanea tarda, profanos, obviously. Sorry, I used the Greek word. And seborrheic pemphigoid. What is the seborrheic pemphigoid? Probably the brasting peripemphigoid, I guess.
The seborrheic pemphigus. Yeah, seborrheic pemphigus.
No, pemphigoid. There is this brasting Laura is correct. I think there is this brasting peripemphigoid, which is quite similar. I mean, on the scalp with lesions that look quite similar to this. True. Tacrolimus, could it be an option? We discussed about it. Do you think that there is a relation between erosive pustular of the scalp and erosive pustular of the legs?
Who knows? This is very difficult.
There is obviously a trigger that triggers this reaction. That's common, probably, but what kind of trigger, we can know. What systemic retinoids to use? We said acitresin with either 10 milligram or 25 milligram. Is it a good idea to combine oral acitresin with local steroids? Of course, yes, but acitresin does not replace steroids. Acitresin is used to maintain
Yes.
as a steroid-sparing agent, so to maintain the disease under control when you stop steroids. Of course, you need steroids at the beginning, always. There is little information about malacentia as etiology of EPDS. Can we use topical antifungals for this? I'm not aware of evidence on malacentia being involved in the pathogenesis of the disease. It could make sense in my view, but we don't have evidence on this. So I have no idea what would happen if you used local antifungals only without steroids. I guess that you need steroids. Differences that, Jeppy, for you, what you said, differences in histopathology.
Yeah, it's mainly related to the deep mitosis that are present in dermal sarcoma while are absent in atypical fibroxanthoma. So pathologist has to check if there are deep mitosis.
But it's a very challenging diagnosis also for pathologists, and that's why I like something that Jeppy always says when we speak about these two entities, that the clinically useful message is that when you receive from your pathologist the diagnosis of atypical fibroxanthoma, which will happen, it's not so rare, so it will happen sometimes in your career. The only thing you have to do is to make sure, to ask him or her if he or she considered the possibility of dermal sarcoma, and he did what he had to do in order to exclude it. That's very important because they are very similar histopathologically.
And another question, what is the best treatment for dermal sarcoma? Surgery, yes.
Yeah,
surgery, and then follow up eventually with echography and so on.
Fantastic. Okay.
Bene.
Jeppy, you have to tell us something, I guess.
Yes, I have to tell you something. And now I learned how to tell you this something with the sound. Let me see it. Okay.
Let's see.
Just a moment. Here we are. Aspetta. I did a mistake. Ok. Condividi suono, condividi, and go. Fantastico.
Beautiful.
Fantastic. Wonderful.
This is a very nice piece.
Absolutely.
Beautiful.
Sebbi is sharing something. Fantastic, fantastic. So this is the
capito?
way we, in the last years, we start our season, let's say. So it's immediately after summer, the last weekend of summer, the last weekend of August, Dermoscopy Excellence Masterclass.
Yeah.
And then
we have a lot of fun at the masterclass. And
okay, so we go to Nisa.
Nisa.
Good evening, my dear friends. Tonight, unfortunately, I'm not with you, but I'm with you with my cases. And I have two cases, two pink facial lesions. And the first one is coming from a 65-year-old male. The lesion is located on the nose with a history of 8 or 9 months. What do you think it is with this dermatoscopy? Let's wait for a while. And here are the options: BCC, basosquamous carcinoma, SCC, traumatized dermal nevus, and microcystic adnexal carcinoma.
I will go for microcystic.
Before giving the answer, I was with basosquamous carcinoma because on the right-hand side of the lesion, we have clustered vessels and keratin on the left side of these clustered vessels, which is dermatoscopically seen as yellow structureless area. So this part, the right part, was SCC for me. And the left part, we see serpentine vessels and fiber sign on the top of the lesion, and on the middle left side, we have ulceration, which is shown as orange structureless area. So that part was BCC for me. So as a combination, this was a basosquamous carcinoma. But histopathologically, it was microcystic adnexal carcinoma. It's a very rare tumor, low-grade sweet gland carcinoma that typically occurs on the head and neck, and particularly on the nasolabial sulcus or periorbital regions. It's a local aggressive tumor. There are some very rare reports of lymph node metastasis, and histopathologically, we have keratin horn cysts, nests, or cords of basaloid cells that are usually more prominent in the superficial dermis. And sometimes tumor strands and cystically dilated tubules are arranged in solid islands and embed in deeper desmoplastic stroma. And there are some specific features like dystrophic calcification, keratinosis, and sometimes granuloma formation. So the complexity of the histopathologic features, which are sometimes similar to SCC or BCC, made this lesion dermatoscopically as a combination of basosquamous carcinoma in the present case. The second case, the lesion is located on the tip of the nose, and the history is 3 or 4 months. And the patient was an 85-year-old female. And here is a dermatoscopy. And with this dermatoscopy, what do you think it is? And here are the options: wart, basosquamous carcinoma, keratocontom or SCC, traumatized septae, or inverted follicular keratosis. Which one? According to me, it was a keratocontom because we have central keratin mass and some blood spots on the keratin mass and peripheral radial vessels. But histopathologically, it was an inverted follicular keratosis. Actually, these inverted follicular keratosis is a misnomer, or there should be an alternative terminology such as there are irritated seborrheic keratosis or wart, because these lesions do not arise from follicles but rather from basal and squamous cells therefore there are some debate in the literature that this name is a misnomer. But some authors think that this is a different entity and it's inverted follicular keratosis. And here are some histopathological subtypes of this tumor: wart-like variant, keratocanthoma-like pattern, solid nodular form, or uncommon cystic type. And these differences reflect the dermatoscopic differences, variations of this tumor. And here are some examples from my clinical practice. Sometimes they really look like a keratocanthoma or SCC, and sometimes they look like a wart or an irritated seborrheic keratosis. And in the slide, you see some other examples. Sometimes really it's a very challenging tumor. So these are my cases, and I wish you a happy dermoscopy, happy hour, and lots of kisses. Goodbye.
Brava, Nisa.
Fantastic,
Our
fantastic,
kisses to
fantastic.
Nisa.
Fantastic. We miss her so very much, and we will not accept any more that she will not be here. No, she will be with us, of course, in the last 2 episodes. Very nice cases, by the way, both of them. The truth is that the first one was really looking like a basosquamous carcinoma dermatoscopically, and the other one was one of these irritated seborrheic keratoses that we slowly become able to recognize. Fantastic. Konstantinos, your turn.
By all means. So I will share 3 cases from the amazing app that we have, Dermoscopy. And let's see, case number 1. This is from Romania.
No, this is not Romania. This is, let me tell you, this should be something like Colombia, Venezuela. But it's not Romania. No.
If someone knows, let's type the country.
Ecuador.
Could be Ecuador. Yes.
Could be.
Okay.
Clinical, and this is the dermoscopy, and you can see the dermoscopy here. And let's see what people think. Sebi?
Sebastiano.
Lichen planus like keratosis. Let's see. The dog wants to play, huh? Now
You already biased the result, Zepi. So,
the dog is tired of the happy hour. He wants to play.
Of course he does. So the vast majority voted for irritated, in essence, seborrheic keratosis. And I think that, the results were very similar on the dermoscopy app. And I think that indeed, this looks like the irritated seborrheic keratosis that we often find on the face.
Bene.
Next case.
Ooh.
On the ear, 50-year-old.
This flag is Australia or New Zealand?
Yes.
Guess what?
Guess what? Australia or New Zealand?
Australia or New Zealand?
It's Australia or New Zealand. This is the clinical, and this is dermoscopy.
Okay.
And what would be your diagnosis?
But this is also another nice part of the happy hour. So we learn about wines, we learn about philosophy, and we also learn about flags.
Yes.
Yeah. Angioma, come on.
95%. I love those numbers.
Yes.
This is another aspect of the lesion. If it moves, sorry, give me 1 second. My computer is abandoning me, I think.
It's not a Mac, that's why.
It is a Mac.
It is a Mac, yeah.
No, actually, yes.
Now we can see the results of the election also in your monitor.
Yes, for now, this is how it goes. And let me just bring it up again. It was...
This one, yes.
here, and what people voted was 94%, 95 here, 94% on dermoscopy for vascular lesion. And I think we can do just one more, which let's do this one that has histopathologic correlation as well. This is the lesion, as you can see here. This is dermoscopy. And what do you think this?
I'm optimistic.
69% solar lentigo seborrheic keratosis, and histopathology confirms the result. Beautiful.
Very good. Beautiful.
Fantastic.
Wonderful. Wonderful.
But which is the current level in dermoscopy? 23, 23. We are
yes,
going
23.
24. Okay, fantastic.
23, and their lesions from Athens.
Yeah. Very good.
Wonderful.
I have to tell you something, guys. I have to tell you something. Are you ready for this?
Yes.
Sure? Are you sure?
Emilius, we're always ready for you.
Okay, then today, of course, we have again the armamentarium.
Armamentarium.
It's finally the day we spoke in the previous weeks about the magnifier, the handheld dermatoscope, the mobile dermoscopy, the Intel Studio. Finally, it's time to say something about the big thing. The big thing.
Jealous about this. Yeah.
Yes. So the Vectra total body 3D imaging that captures 3D cross-polarized and non-polarized images in milliseconds. Of course, then you need a few minutes to reconstruct the avatar, but the 3D image is not an avatar. But it's very, very fast, saves clinicians and photographer time and effort. And also, it enhances, look at this, it's fantastic. It enhances the lesion assessment and tracking, also increases patients' comfort, reduces anxiety. Well, this depends. And what I particularly like very much is the last thing, which you can see here. This is my strong belief, is that this, not only this kind of 3D imaging, but also the high quality 2D imaging in the near future will be used, of course, to assess skin tumors, nevi and so on, but also for, in many other indications in dermatology. And these are some examples: widespread psoriasis, widespread atopic dermatitis, vitiligo, lymphomas, and in general, eruptions with which are widespread can be assessed much better with a great total body imaging. And this, of course, is an exceptional example of a total body 3D imaging.
Yes.
So that was it.
Perfect.
Now we are almost there. There are a few more things that I would like to share with you. Starting with a gift that I have today for all of us. And who is the sender of the gift? It's
Penelope.
Can you guess? No, you cannot guess.
No. How could we?
You cannot guess. Our dear Penelope, who also has to prepare something very special for the last 2 episodes. I mean, we have. Yes. She will. I'm sure that she will. But so, related to the topic of the previous week, as usually, pigmented lesions on the face, clinical. You can see here. They are obviously similar one to the other, most of them. And here is dermoscopy. So let's try quickly to say, what about number 1, instinctively?
Solar lentigo.
Solar lentigo 2.
Again.
Sub-K.
Solar lentigo 3.
LPLK.
LPLK 4.
Desmoplastic melanoma.
Melanoma 5.
LPLK.
Okay, 6.
Solar lentigo.
Solar lentigo. You did not do very well, let me tell you. But you caught the bad guy, so it's very important that you found the nodular melanoma, which was, of course, I don't think it's nodular melanoma. I think it's lentigo maligna melanoma with a nodular component, because also the periphery is a flat component of the melanoma. And then we have Bowen's disease, lentigo maligna, the second, pigmented AKA the third, LPLK the fifth, lentigo maligna again the last one. By the way, quite strange. It's on the ear. That's why. That's why it was unusual in terms of being reticulated quite a lot. Send us your cases, because one of the two next episodes will be devoted to your cases exclusively. And now, before we say goodnight, we will play a little bit as usually.
It's
with our.
To say
Are you behaving good or bad, Emilio?
Emilio.
I would say mixed.
Mixed.
Yeah.
In the middle.
No. I think I changed a couple of cases, so I became good. I will be good. So join. This is the pin. You can scan the QR code, or you can type www.kahoot.it, select your nickname. Don't worry if you don't appear on the screen. Don't worry if you get a message that you are not connected. You will be connected as soon as I start the game. And we give you 5, 4, 3, 2, 1. Basta. Let's start. Episode 18.
Incredible, huh?
Incredible.
18 Sundays.
18 Sundays, exactly. First case. I mean,
yes.
You are dermatologists. You are used to use morphology to extract many conclusions, including the age. So I don't tell you the age, but I guess you can understand. Yes. The lesion looks like this. I mean, I think quite strange. Yeah. Dermatoscopically, it looks like this.
Okay.
And now we have to vote. If you think that this is a nevus or a melanoma. Am I not good?
Yeah, you are very good.
You're good.
Very good. Very good.
Okay. Thank you. So we will have a majority of, we will have 135 correct answers, not 83 correct answers.
Very good.
It's a nevus with a pattern that is rather looking like peas in a pod. I mean, it's a parallel furrow, but there are also some dots. So it's most probably congenital nevus or congenital type nevus of the acral sites. Chichi. And
Chichi. We know Chichi.
We know Chichi. Okay, fantastic. Let's go to question number 2. On the leg, 2 lesions. This is the photo from a distance. This is the close-up clinical. This is the dermatoscopic image of these 2 lesions.
Okay.
Yeah? Okay. Good.
Okay.
And now my question is, true or false? One is melanoma and one is BCC. True or false?
True or false? True or false?
Now the dog is complaining, saying, you told me 1 hour and it's already 1 hour and 7 minutes.
Yes.
It's false. It's false that this was 1 melanoma and 1 BCC, because the correct answer is that
they're both BCCs.
They are both BCCs. Quite unusual location for BCCs, but that's what they are. The left one, by the way, a nice example of white, shiny strands or blotches in squamous cell carcinoma. Very good. And this brings Bedostigi in the first place. Sleepy blobfish. And sometimes, look again, sometimes.
We love sometimes.
Question without points. All these wines are from Spain, except of Rioja, Priorat, Ribera del Duero, or Blaufränkisch. Come on. Am I not good?
Blaufränkisch.
Blaufränkisch. Also, the dog is getting scared about Blaufränkisch.
Which, by the way, a question for you guys. Where is Blaufränkisch from?
Austria.
Austria.
Bravi. Austria. Very nice red wine, by the way.
Yeah,
No
beautiful.
points for this, unfortunately. And then we go to the next question, which is again 2 lesions. On the left, we care about the small nodule, which is in the circle, not about the flat one. It's on the trunk. It's a small nodule on the trunk. On the right is a small nodule on the forehead, on the face. And this is dermoscopy of these 2 lesions.
Okay.
Okay. And now my question to you is, which is BCC? None, left, right, or both?
Aha.
Very similar lesions, but
and the answer is, so
Where is
people
the answer?
vote for left, while the answer was that both
Oh, yeah.
were BCCs. But why this right one was so?
because I think that looks like a traumatized IDN.
No. But I will show you in a moment. That's the problem of the Kahoot again, because
Yes,
if I show you the image,
Yes.
I will do it when we finish, just for curiosity to see how beautiful it is in the real image. So it's a quite easy BCC in reality. So we have Picky with being in the first place, and now this brings us to the next question. This is a solitary lesion on the scalp. This is clinical morphology. This is dermoscopy. And now my question is, what is this strange thing? What do you think that it is? Answers. It's simply a blue nevus. It's a malignant blue nevus. It's a melanoma metastasis. It's a basal cell carcinoma.
Does the patient have a history of melanoma?
No,
Okay.
not known at least.
Yeah, wow.
Yes, it's simply a blue nevus with a nice projection. I mean,
Yes.
yeah.
Cometa.
What is this projection? Probably lymphatic somehow.
I don't know. I think it's just
Just the shape. Yeah.
just a
Well,
shape. He was-
Fantastic. So this brings, no, Picky still in the first place. Fantastic. Athaide is the second. Next question with no points. True or false? The next IDS World Congress 2024 will be held in Napoli. True or false?
False.
Don't influence the votes.
2024. Why not? Come on. Why not?
2024. Will it be Napoli?
No,
No, not in 2024, but instead, no points here, of course. Instead, this is where the next World Congress is going to be held. Yeah. Buenos Aires, October 16th to 19th. Start booking your travels.
Yeah.
It's going to be fantastic, I'm sure. I'm so much looking
It'll be
forward.
fantastic because we were waiting for this Congress for the last 3 years.
8 years.
6 years. It was 2018. Yeah.
Yes. It's now 6 years, but let's say for 3 years, it was supposed to be held 3 years ago. Yeah.
Fantastic. And now the next one, unfortunately, again, blurred the image, but I think that we can see what we need to see. This is dermoscopy.
Yes.
And now my question to you is, what is this? Is this a Saturn nevus? Is this a melanoma with regression, basal cell carcinoma, or morphea? And I can tell you for sure what it was because we excised it, because it was not in a child, and it was solitary, so it was strange. But you were correct. This was just an halo nevus. And now let's see what happened. Third place today for Athaide. Very good.
Bravo, Ataid.
Second place, Seb KK. And the winner of the evening is Piki. Piki.
By the way, you know who is Seb KK, right?
No.
Kazia. It's always KK.
You think so?
Yes, by all means.
To be. But we know Piki already, right?
But Piki should be extremely proud. If Kazia was the second, Piki should be extremely proud because you won the world champion of the champions.
Exactly. She was able to beat Federer, you know?
Yes.
Mariana, join us.
Mariana, where are you? In the meanwhile, but just from curiosity, let me show you, let me do it. I'm sharing my screen and look now this BCC, yeah?
Yeah. It's
You
nice.
see?
Yes.
Yeah. Beautiful.
The thing is that,
The best spoke wheel areas ever.
yes.
Yeah.
Eccola.
Hi, Mariana.
Hello.
Hi.
Hi, Mariana. Congratulations.
Mariana, how old are you?
31.
31. So you are still in the range of the best winners, good in dermoscopy and young enough to make a good job.
I'm doing my homework. I'm still a resident.
Where are you from?
Venezuela.
Oh, really?
Beautiful.
Wow, fantastic. So thank you so much for being with us.
And thank you for playing.
And many congrats. Keep up the great work.
Bye.
Bravo, Mariana.
Fantastic.
Oh, brava.
Fantastic.
By the way, just one very short comment, right, on the blue nevus that you showed. Like the day before yesterday, I had a patient who came in with a blue nevus. I was like, yeah, that's a blue nevus. And the patient was, I went to two colleagues of ours, and they told me that a blue nevus is a ticking bomb ready to become a melanoma. It's like, no. And the patient was horrified. Like, guys, blue nevus is a blue nevus. It's nothing. Don't horrify me.
This is something which is especially related to the fact that in the past, I mean, we were not able to make a proper diagnosis of blue nevus, and sometimes we thought it was a blue nevus, but instead, then excising it, it was a nodular melanoma. That's why it was growing up this feeling that the blue nevus could be related to a worse, risky situation.
And of course, unfortunately, there is this classification of the WHO that we commented previously in one of the episodes. And among the many strange things that they propose, one of these many things is that there is one of the pathways for melanoma formation.
Blue nevus is shade melanoma, yeah.
Is blue nevus with intermediate phase and malignant transformation, which...
By the way, we don't have to open more discussions because now it's time to say goodbye. Enjoy the evening. Have a nice glass of wine or beer. And ragazzi, I love you.
Or gin.
Or gin.
Thank you all, guys. From all over the world. Thank you.
Ciao.
We love you.
Bye-bye.
We love you.
Zepi, we adore you.
Ciao, Sebbi. Ciao, Sebbi.
Ciao.
Next week.
Ciao.
Bye.
Bye-bye.